Hello, my name is Sumin Ha from Seoul National University Hospital. I will discuss about my article named Detection of Contralateral Breast Cancer Using Diffusion-Weighted MRI in Women with Newly Diagnosed Breast Cancer, Comparison with Combined Mammography and Ultrasound. Diffusion-weighted MRI imaging measures mobility of water molecules within our tissue, which reflects microcirculation, cellular density, organization, and membrane integrity. Breast cancer shows restrictions on high B value, which appears hyperintense, and low signal intensity on corresponding ADC map. So looking at prior researches, the WMRI screening standalone sensitivity shows 72%. And compared to mammography, among 118 mammographically occult lesions, the WMRI detected 89% of the CMR detected cancers. The WMRI still shows relatively low sensitivity compared to the CMRI, and compared to ultrasound, among 16 mammographically occult cancers, the WMRI detected more compared to the MRI-guided focused ultrasound. And as a combined role, combined the DWMRI and DCMRI shows higher specificity compared to DC alone because less false positive results. So, our hypothesis was that DWMRI as a standalone test should be superior to digital mammography and ultrasound in detecting clinically occult contralateral cancer in women with breast cancer. Therefore, we try to compare detection rates of clinically occult contralateral cancer and positive predictive value of biopsy recommendation between DWMRI and combined mammography and ultrasound in women with newly diagnosed breast cancer. So this is the study population flow chart. The retrospective review of our radiology department database identified 1,931 consecutive women with breast cancer who underwent preoperative breast MRI, and radiologists performed ultrasound for local staging between January 2017 and July 2018. Exclusion criteria were women who were treated with chemotherapy before surgery, had symptoms in the contralateral breast, no available mammography data, or poor DWMRI image quality, missing pathological data on tumor characteristics, or has been followed up less than 1 year. Finally, 1,148 patients were included. 3 breast radiologists independently assessed all the WMRI images of the contralateral breast in 1,148 women. The radiologists were blinded to the CMRI, mammography, on ultrasound, and histological findings. First, if you see the interpretation flow, any unique area of high signal intensity were identified on the WMRI, which was composed of p-value of 0 and 1000, and the ADC value was measured. The suspicious DWMRI findings included irregular shape, non-circumscribed margin, rim or heterogeneous internal signal pattern, segmented distribution, and low ADC value with cutoff of 1.25. Virus category 1 or 2 assessments was used for examinations without any high signal intensity lesions or hyperintense lesions without any suspicious features, while virus category 3 or 4 or 5 assessments were used for findings with more than one suspicious finding. Radiological reports were retrospectively reviewed by the radiologist whether the finding was seen on mammography and ultrasound and their virus final assessment category. The reference standard was the results from the biopsy, surgery, and clinical or imaging follow-up of at least 1 year. And MRI, we use 3 Tesla MRI, and for the WMRI, the V values were composed of 0 and 1000. Virus categories was dichotomized with negative composed of virus category 1 or 2, and for positive composed of virus category 3, 4, and 5. For subgroup analysis, we calculated cancer detection rate according to the characteristics of women and the breast cancer characteristics. We calculated cancer detection rate, sensitivity, specificity, abnormal interpretation rate, and PPV1 and PPV2. P-values for differences in PPV was calculated using generalized estimating equations, and for other comparisons were based on McDonald test, and Bonferroni correction method was used for multiple comparisons. So this is the results. So 30 cancers were diagnosed, and there was no significant differences between patient characteristics in women with contralateral breast cancer and without contralateral breast cancer. Contralateral breast cancers included invasive ductal carcinoma in 43.3%, which is 13 in out of 30, with a median size of 1.0, and the CIS in 56.7% with median size of 2.4 centimeter. None of the cancers was associated with lymph node metastasis. Looking at the grades, invasive cancer and the CIS showed highest percentage in intermediate grade, and luminal type was the most common type, and breast conservation was done more compared to mastectomy. Of the 30 contralateral breast cancers, the WMRI detected 23, which is 76.7%, whereas mammography combined with ultrasound detected 12, which is 40%, which showed significant differences between the two. The WMRI detected more contralateral cancers compared to combined mammography and ultrasound in women aged younger than 50 years, and also in women with dense breast tissue, and also with women with invasive cancer histology or lesions with pathological tumor size larger than 1 centimeter. The cancer detection rate of DWMRI was higher than the combined mammography and ultrasound, with 2.0% compared to 1.0%. For invasive cancer only, the cancer detection rate of DWMRI and combined mammography and ultrasound were 1.0% and 0.4%, and the differences were significant. The sensitivity of the WMRI was significantly higher than the combined mammography and ultrasound at 76.7% compared to 40%, while the specificity of the WMRI was not different from that of combined mammography and ultrasound. The abnormal interpretation rate of the WMRI was not significantly higher than that of combined mammography and ultrasound. The PPV1 and PPV2 were higher than combined mammography and ultrasound as 14% and 42.1%. All invasive cancers detected by combined mammography and ultrasound were also detected using the WMRI. 2 cancers manifesting as calcifications were detected by combined mammography and ultrasound but missed by the WMRI. 5 cancers were missed by all imaging modalities, which included invasive ductal carcinoma and 3 DCIS. The WMRI missed 7 cancers, which were composed of 2 invasive cancers measuring less than 0.5 centimeter and 5 DCIS. The The bar graph shows the number of clinically occult contralateral cancers detected according to the imaging modality. And as you can see, the WMRI shows highest detected cancer rate, also in invasive cancer and DCIS compared to mammography alone and mammography combined with ultrasound. So these are the cases. Image of 45-year-old woman with 0.7 centimeter invasive ductal carcinoma in the left breast. The WMRI shows irregular mass with high signal intensity in the outer breast. The mass shows low ADC value, which was assessed as virus category 4. Mammography shows negative findings, and initial ultrasound showed negative finding, but targeted ultrasound after MRI shows irregular hypoechoic mass with non-parallel orientation in the corresponding area to the DWMRI. Ultrasound guide biopsy and surgery revealed low-grade node negative invasive ductal carcinoma. Image of 31-year-old woman with 1.2 centimeter ductal carcinoma in the right breast. The WMRI shows irregular mass with high signal intensity at the glandular fat junction of the posterior breast. The mass shows low ATC value and was assessed as virus category 4. Mammography showed negative findings and was negative on the initial ultrasound. Targeted ultrasound after MRI shows hypoechoic mass in the corresponding area on the WMRI, and surgery revealed a low-grade DCIS. Image of 50-year-old woman with 6.6 centimeter DCIS in the left breast. The WMRI shows no suspicious findings, which was missed and assessed as virus category 1. Mammography shows group of pleomorphic calcifications, which was assessed as virus category 4. Ultrasound shows indistinct hypoechoic mass with calcification in the area corresponding to the mammography. The combined mammography and ultrasound assessment showed virus category 4 suspicious, and surgery revealed intermediate grade DCIS. So in conclusion, DWMRI detected significantly more contralateral breast cancers with less biopsy recommendations than mammography combined with ultrasound. Our results suggest that DWMRI has the potential as a screening tool for breast cancer detection, especially in women who are contraindicated to contrast agents and cannot tolerate long MRI scanning times. To better determine the role of the WMRI as a screening tool, multicenter prospective trials using standardized acquisition and interpretation protocols are needed. Currently, the WMRI screening trial is underway in Korea, investigating the role of the WMRI in screening high-risk women. Thank you for your listening.